Hi, I'm Megan Kruse, breast medical oncologist at Cleveland Clinic and director of breast medical oncology. Joining today with my colleagues, Dr. Gradishar and Dr. Khan, to talk about T-DXd across the breast cancer treatment continuum, neoadjuvant, adjuvant, and metastatic sequencing approaches. I'd love for my colleagues to introduce themselves.
Hi, I'm Dr. Bill Gradishar, breast oncologist at Northwestern here in Chicago.
Ajaz Khan, City of Hope here in Chicago, and I'm also a medical oncologist.
Thank you. So it's been quite the year in HER2-positive breast cancer, I think, to say the least. It's amazing, actually, how much data we've seen in the past year. I had to actually stop and sort of pinch myself to think about when these trials came about. So can we talk a little bit about how you contextualize the importance of early-stage HER2-positive breast cancer treatment and what having new data in this space means? Bill, what do you think?
Well, I'll just make a couple of comments. I think, the ultimate goal, obviously, is to reduce the risk as much as possible that you're ever dealing with metastatic disease. So we can do that in a number of different contexts. Obviously, for those patients who may have had surgery first, we have strategies for those patients who require preoperative therapy because of the size of their tumor or their nodal status. We now have additional strategies that can markedly reduce the risk of, subsequent residual disease. And for those with residual disease after preoperative therapy, we have newer strategies that employ good drugs that seem to markedly reduce the chances of a problem downstream. So I think all of these things really amplify, our abilities to make sure patients do well over the long term.
Right, which is absolutely the goal, right? This is what we have great options in the metastatic setting, but we don't want to have to use them. So we want to maximize first. Dr. Khan, your thoughts about advances that we've made in the last year?
First of all, I agree with everything that Dr. Gradishar said. I think it's also an exciting and changing landscape. One of the most powerful drugs that we've seen in the metastatic setting is now available in the neoadjuvant and adjuvant setting with these new trials and these new options that we have to bring into the clinic to our patients. So I think that's extremely exciting in terms of survivorship and, more importantly, reducing the risk of recurrence.
Yeah, it's hard not to be excited about the potential for a drug like trastuzumab deruxtecan when you see the impact it has in the metastatic setting. We know we want to cure more patients, and you hope that this will get us there. And last time we had this conversation, say 6-ish months ago, San Antonio, a lot of this was hypothetical. We were saying, how would we apply it? And now it's here. Now we have approvals in the neoadjuvant adjuvant space. So Dr. Khan, why don't we start with the neoadjuvant space? Do you want to walk us through DESTINY-Breast11 and what it told us?
Sure. So first off, it's a brand new trial design in terms of looking at the standard of care that we have currently, which is an anthracycline-based compound regimen in combination with taxane-based regimen following that, versus Enhertu, which is one of the trial arms, versus Enhertu in 4 cycles followed by THP, which is a taxane and Herceptin and Perjeta. So this was the first trial design we've seen like this, where we're actually using an ADC compound in combination or followed that by chemotherapy. So 4 cycles of each versus 8 cycles of Enhertu versus 8 cycles of standard chemotherapy, which we saw in approximately just a little over 300 patients in each of these arms. And what we really saw, what we wanted to see ultimately, was a PathCR. And there was a significant difference of more than 9% between standard chemotherapy versus Enhertu and THP in terms of combination therapy.
Yeah, and I think the bar was already pretty high based on our standard of care regimens. And actually, so to see a regimen do this well is encouraging. What are your thoughts on what that means for overall outcomes?
Well, we'll have to wait and see. But, the other thing, just to expand on a couple of things that were said, even in the ER-positive patient population, we're seeing a markedly elevated PCR rate, which is beyond what we've typically seen in that group of patients. We're very accustomed to seeing a difference in PCR rate between ER negative and ER positive. And there still is a difference, but the amount of benefit you get in the ER positive patient population was significant with T-DXd. So that was obviously very encouraging. And what we want to see, we don't have data yet that's mature, is what is the downstream effect of this? Obviously, the more patients that go into PCR, We know that those patients do better over the long haul, and they don't require, even using old standards like TDM1, they may not need that. They may get away with HP, and as a result have less toxicity. So I think the more patients that we can avoid giving non-HP like post-adjuvant or post-neoadjuvant therapy to, it's better for them. And then ultimately, of course, we want to see it translates into an improved overall outcome.
And what do you think about the tolerability of this regimen? I think we've all thought about both the day-to-day toxicity, but also the long-term toxicities that may come with use of T-DXd in this curative intent population. So what are your impressions of the trial?
Well, to date, everybody, when the drug first came out, was very worried. There was a black box warning, ILD is going to knock down everybody and it's going to be a big problem. And I wouldn't minimize it. I mean, it's still something we have to be sensitive to, but it happens infrequently with high severity. We'll talk about DB05, but even Michael Lynch, just a few hours ago went over the ILD data in DB05. And the fraction of patients that had significant ILD was pretty modest, and most of it was low grade, and most patients could continue. And I think that's generally been the experience.
It's been reassuring, I think, and having that data in hand, I think allows us to better counsel our patients, because hearing that toxicity, I can imagine some of them are going to be a little bit worried about the impact. Yes, they want the best thing for their cancer, but they also don't want to end up with a life-altering or potentially life-threatening complication of it, right? And it's a very sensitive conversation to have when you're consenting a patient for this treatment. So how would you go about that, Dr. Khan? What do you tell them about monitoring and safety?
I think there's three aspects to it. One is to educate the patient, to make sure that they're aware of what those symptoms are, and to make you aware and your nursing staff, along with the people that take care of that patient, that they're aware of what's happening. The second thing, I think, is having really a good pathway design within how to model it, and in terms of how to take care of the patient if there's symptoms that arise. The other aspect, I think, is really having vigilance in terms of doing CT evaluations on these patients early on, and then also having pulmonary follow-up, and really having a good communication system by which you can do that. So I think those things are really super important.
Yeah. Are there lessons learned from the metastatic experience with T-DXd that you would either plan to apply in the space or already applying in the space?
Great question. And I think the challenges there are how do you go about really structurally organizing that system, right, operationally speaking. And for us, we see enough patients in this realm that we're really vigilant in terms of making sure that we're going about monitoring that patient, either myself or even my advanced practice providers that work with me and alongside with me seeing these patients. We're trying to make sure that we're asking these questions every time we see the patient.
Great. And we'll come back to this a little bit as we talk about the DB05 data, Bill, that you brought up, because I think contextualizing, now we have two options, right? We can use pre-surgical therapy, we can use post-surgical therapy, and that gets a little tricky as to who we decide is right for which approach. And I think the lung toxicity and monitoring may play into that to some degree. In terms of how you would talk to community providers about, at present, the best patient you can envision for neoadjuvant T-DXd containing regimens, do you have ideas of who that patient might be?
Well, I'm not sure that every single patient is getting neoadjuvant therapy needs to get T-DXd, number one. If you go by the criteria in the trial, these were higher risk patients. And the reason I say that is because you may have a patient that just fits, just over the cusp of what you think even needs neoadjuvant therapy. So is that somebody that you're going to give T-DXd to and THP? Is it wrong? No, it's not wrong, but do you need to do it? I'm not sure you do, because a lot of those patients are probably going to be benefited to the same degree getting something less. So for somebody who certainly fits the criteria, high-risk disease, big tumor, lots of nodes, no qualms about following that regimen.
Yeah, it's an interesting intersection of both our de-escalation and escalation strategies all existing within a very similar patient population. I think there's a very clear patient population, as you described, positive nodes, big tumors, young patients, where we feel very comfortable, but there's a big gray zone here. And I think the label kind of highlights this. It's really for stage 2 and stage 3, but those patients can be very heterogeneous. So Where do you see some of the complications, Dr. Khan, about what might be your gray zone cases?
Yeah, and so the comment that I'm going to make is that the discussion and evaluation is not always binary, right? So in other words, just by seeing the patient, we can't just always make the decision right away. Part of that discussion is multidisciplinary, and then also what I talk with my colleagues about, in terms of enrolling a patient. So I think somebody that's younger, that may have ER-negative disease, and as Bill alluded to, just what the trial said, someone with a T3 tumor or positive lymph nodes or high risk of potential metastases down the road, I think this is the regimen I would choose for them. I think the challenges would be these ER-positive patients, lower volume disease, lower nodal burden. Do you go with the classic regimen that we've had, or do you go with, with the new regimen based on the data that we have right now from 11? Yeah. So I think those are the questions, and then the surgical input is really important as well.
Yeah, absolutely. It's definitely not a decision that you can come into a patient's room knowing what you're going to do. I think talking with them, hearing what their performance status is like, doing your physical exam, it all matters. And in centers like ours, where we're able to have the multidisciplinary conversations, I think that really helps. For our community providers who may not be seeing patients until after a surgeon sees them, what are your thoughts on the importance of a medical oncology opinion for HER2-positive patients from the beginning?
The challenge always in the community setting, I think, is how the time frame in terms of when the surgeon sees the patient and then when you see the patient, and then how many weeks go by or how many days go by in that situation. The other part of it is that, do we have all the pathways delineated or not? I work at a very similar academic type system where, all these patients are discussed at a breast tumor board. That's not always the case at the community setting, and sometimes you're making a decision based upon the data, but then do you have all the other elements in the equation, right? Do you have pathways set? Do you have a multidisciplinary conversation with these patients? And how well is the communication between the surgeon and the medical oncologist? I think those are all the parts of the equation as well.
Yeah, I think at our center in particular, we have said that HER2-positive patients should meet with a medical oncologist up front, not always because we're going to use this specific approach, but that we might be using an alternative neoadjuvant approach that then informs the next piece of our conversation. Or we can assure our surgeons that actually this is someone who may benefit from a de-escalated regimen down the line. And getting that right up front, I think, is crucial for these patients. Yeah. So thinking about the other options we have at our disposal. So DESTINY-Breast05. So you got to explain DESTINY-Breast11, Dr. Khan. Dr. Gradishar, would you like to take DESTINY-Breast05?
Yeah, so DB05 is sort of a successor to Catherine. And TDM1 has been sort of the standard treatment approach for anybody that has residual disease having received neoadjuvant therapy. And it's a standard that we've, adopted because it was pretty compelling from the data that's matured over a long period of time. So once we were seeing the activity of T-DXd in a number of different settings, including the metastatic disease setting, it was sort of a natural question to ask, could you confer an even greater benefit by using a perhaps more potent, effective drug compared to TDM1 in that same setting? And DB05 actually demonstrated that. And again, these were higher risk patients, who went into the trial, and the randomization was T-DXd or TDM1. And the patients who received T-DXd had a meaningful and clinically relevant improvement in event-free survival, I guess around 8-9%. So that is not something where you have to squint to see the results. And I think as a result of that, I think most people now would adopt T-DXd for residual disease over TDM1. And TDM1 has sort of started to move back again and, where we think about using it. There are, of course, trials looking at other things, TDM1 plus tucatinib, other things that, may potentially still keep it around. But today, based on what we know in the approval and it's in guidelines, I would think about T-DXd.
Yeah. And I think the approval is very interesting. The approval is really for patients with any residual disease after neoadjuvant chemo. So how do we feel about that?
I think it's a good question. And, those patients with very small volume disease, negative lymph nodes, how much more benefit are you going to get with this compound versus the standard that we have, which is TDM1? I think the other thought process also is, what are these patients that we're treating as well? There's also significant toxicity that we do know that occurs with T-DXd versus T-DM1. Toxicities are different, but there's also a higher chance of ILD in these patients with the number of cycles that they're getting, which is 9, right, in the adjuvant setting. So I think those things are also important. The data that we do want to see moving forward is the potentially brain metastases in terms of how that affected it, and then the more mature data in terms of disease-free survival beyond 3 years as well.
And in terms of the patient selection in DESTINY-Breast05, I mean, I think it was intentionally designed to reflect this high-risk population. In my mind, patients with residual disease in general, I'm worried about. And so I think there are probably many patients not captured in the original study that could be candidates for this. I don't personally have a lower limit of threshold of amount of residual disease at this time that I would think about omitting it for. Curious though, because my thoughts are evolving on this, do either of you, are there patients you wouldn't approach with this?
Well, you think back to when TDM1 post-Catherine, we would see like one little millimeter or something. Then you're trying to be a purist and say, well, they should go on TDM1. But do they really need it? Right. And I don't think that the process in our brains is any different with T-DXd. If you had, a really fantastic response and you just had a little ditzel of disease, I might debate with myself whether they really need T-DXd or not.
Mm-hmm. Yeah, I agree. How about hormone receptor positivity? How does that play into it? You brought up earlier, we're expecting the PCR rates with the T-DXd neoadjuvant regimen are better, but we're still going to have a fair number of patients, regardless of their neoadjuvant regimen, that will have residual disease with hormone receptor positive disease. So how does that influence decision-making in this space?
I think those patients with high volume disease that started out, prior to their neoadjuvant therapy, as the way they were enrolled on the 05 study, I think those patients I would still consider them for T-DXd. I think the smaller tumors I'm still going to be very controversial about, in terms of, in my mind, just as Bill said, I think these are the challenges that we face in clinical practice all the time. They're going to benefit from an AI or they're going to benefit from tamoxifen. The question is, what else are you going to add to that? Are you going to do a patina-like regimen for these patients as well? And then how will that interplay with what we're doing in terms of their HER2 therapy as well?
Yeah, I think we'll have to think about that carefully and individualize because as was said, I mean, if you had a very high-risk patient, had residual disease, that was probably a patient, if they were ER positive, that wasn't HER2 positive, you'd be giving a CDK4/6 inhibitor too. And we don't have the same data in HER2 positive population, but oncologists are creative. I could envision this being done.
Mm-hmm. It's hard to know what we know about activity of drugs in different settings and not want to apply it in a disease state when you have a patient sitting in front of you.
You can't unknow things.
That's true. There's no putting that data back in the box. So now that we have these two approvals, the data came together, the approvals came together, it puts us at a very interesting place where there will be many overlapping patients where we could go either way and be fine. Is there any part of the regimen, whether it's side effect, tolerability, schedules, that influences you with a preferred approach, or will you go in with each individual patient with an open mind?
I think it's a challenge, right? Particularly the frailer patients with known history of lung disease. I think those are the patients I think you have to counsel, and then I think you have to kind of even weigh within yourself what are the challenges going to be as we treat this patient in terms of response and also weighing toxicity along with that. I think those are the challenges. I think the easier part will be, so there's ER negative, right, young patient with minimal problems. I think those challenges will be a lot easier in terms of.
It's a little more automatic in that situation.
Yeah, I don't think I would be too dogmatic, knowing exactly what I'm going to do before I set eyes on the patient. Because you may ultimately, again, individualize, go from room 8 to room 9 and have two different approaches for a patient that's not so dissimilar but may have comorbidities or age or there are a lot of issues.
Yeah, it actually makes me feel better to hear you both say that, because I feel like presented with the same situation 10 times, it's going to be 5 of 5 and 5 of the other, just with those nuances of how do you feel as you're talking with the patient and what are you picking up on. So there's a big unanswered question here that is the elephant in the room. Let's say we use the DB11 approach. Our patients hopefully are getting pathologic complete response, but some of them won't, right? What do we do for a patient who had DB11, has been exposed to T-DXd, and then has residual disease at the time of surgery? Acknowledging we don't have data on this. But can we help our colleagues out?
I think it's a challenge, right? And so now you're exposing the patient to 14 cycles, right, of T-DXd.
So you would start with T-DXd in the neoadjuvant, and then you'd revisit it in the adjuvant setting.
And as Dr. Gradishar said, he said, you know, oncologists are what? Very creative, right? And so I think you kind of take the data and try to be additive in that situation. But knowing that, I think that's one of the challenges. What we don't know is the ultimate ILD toxicity to these patients. How much vigilance are you going to have in terms of monitoring these patients? And then the other side effects, right? The GI side effects, along with the cytopenias and peripheral neuropathy that we did see in DB05. How much will that be impacted by how we change the regimen in terms of going from neoadjuvant to the adjuvant setting?
Okay. So you wouldn't rule out that there still may be more activity of T-DXd that we can squeeze out for these patients?
We just don't know at the moment.
You know, and again, it's an extrapolation, but the data that Park presented about the depth of the PRs, and if you had a deeper PR, so suggesting that if you continued therapy, maybe you're conferring a benefit.
Yeah.
So it's an extrapolation to put it in this setting, but it's sort of the same message. You know, if the patient was tolerating T-DXd up front, still had residual disease, I would also think about continuing, because maybe you could deepen the effect of the drug with longer therapy.
So that's the data that we saw at this meeting, where for metastatic patients, the depth of response actually may have taken a little longer for most patients to reach their maximal response.
Right.
80% by 2 years in the metastatic setting, which I don't know that any of us would have actually picked that particular number. At least I wouldn't have. It's a little longer than I expected. And I think some of us were swayed in the third arm, in DB11, where the patients had T-DXd for 8 cycles, and that arm didn't seem to perform as well, and so was shut down. And what we have seen is T-DXd for 4, followed by THP, as you said, versus the standard. But I think that metastatic data actually is reassuring, that maybe the answer is longer duration, and it was more than those 8 cycles that we originally saw. So, because at the end of the day, we're just guessing with any of these durations, right?
Absolutely.
So coming back to that longer duration and the ILD again, I mean, this is a recurring theme in a curative intent population. We don't want to do harm. So in the studies, there was more intensive monitoring for ILD, right? Particularly as we thought about this curative population getting radiation. Can you speak to that a little bit, about what you envision your actual monitoring strategy to be and how closely you would stick to what they did in the trials?
Yeah, I think it's going to be a challenge, and I've seen, you know, colleagues do it every 6 weeks, sometimes even every 2 months, in terms of even those patients that are getting treatment in the metastatic setting, just to prevent ILD and to catch it as quickly as possible before it becomes from grade 1 to grade 2, and to start your steroids early and get your pulmonary doctors involved. So I think that might be what the approach that we may end up taking. Unfortunately, right now, there's not a clinical pathway yet designed in terms of monitoring these patients, as the data is so new.
Yeah, you know, we maybe have gotten a bit lackadaisical. You know, we sort of are, maybe it's just we've been using it now for a few years, that we feel comfortable. And, you know, I'm not sure that the interval between scans is any different for most patients than the restaging kind of things that we would typically do. In a post-neoadjuvant residual disease setting, where they may be getting it and you wouldn't be typically doing scans, that's what's going to be different, because we don't do scans in that setting.
Right. Yeah. I found myself actually getting some scans in this setting already, being in the Midwest and having to deal with a lot of lung nodules. So I feel like we may actually be used to this a little bit, but I think that will make the conversation even more complicated. And in many of our populations, depending on the time of year, we're going to see changes on a CT scan of the lungs, right? Especially after radiation. I think it could be hard to sort out. But to your point, Dr. Khan, about the early steroid intervention, I think it'll matter for this population, right? If we're unsure,
Absolutely.
and it could be a life-altering toxicity that you wouldn't be able to continue therapy if grade 2 disease or grade 2 toxicity develops, then I think we have to act early.
Absolutely.
Speaking of that, if you had a patient that you're treating in the residual disease setting and they do develop toxicity, what do you see as your strategy to then switch them over to adjuvant therapy?
So usually I start the steroids up front very quickly and keep monitoring the patient very closely until the symptoms actually, abate, right? And then the other issue is how long are those symptoms are persisting for as well. And more importantly, being able to counsel the patient through that process as well, you know. And it's a challenge, right? Because this is a drug that potentially is curative treatment. And how do you hold curative treatment versus where we're doing a palliation type therapy? Right. You know, it's a very different argument, a different conversation as well. And then the question then is when they're going to restart. You know, once that toxicity reaches grade 1, do you feel comfortable restarting the patient? And now you're talking about the patient variables as well.
Yeah, so you're envisioning that if a patient has some symptoms where you're not sure if it's really T-DXd related,
Right.
you would give some time, really get a sense of if there's another reason for it. And if you thought that there was a competing reason, you would resume the drug and give them the benefit of the doubt. Well, I think we're also hoping with the CT monitoring that will catch a lot of toxicity that is radiographic only, right, before symptoms.
Right.
And certainly that would be a situation in which we're able to certainly give the steroid, salvage that, and then hopefully bring therapy back.
Absolutely.
Yeah.
Yeah.
So the goal for you, it sounds like if it's low-grade toxicity, your goal would be to get back on T-DXd.
Yeah, and we have a set number of cycles. We're not treating, you know, until progression, right? So I think in that sense, you have a pretty good idea as to when you want to get that treatment back going, and then hopefully end the treatment as soon as possible. Hopefully not having any further toxicity or complications from that process as well.
Bill, any different?
No, and you know, I think the obvious, if you were near the end of the total number of cycles, I'd probably call it a day and pull the plug. But I agree, that would be the framework that I would think about operating under.
Again, completely individualized. We'll just have to see how it goes.
Yeah.
Yeah. And real world data in the space is really going to help us tremendously.
100%.
So, anything else toxicity wise that for our audience who, you know, may be familiar with T-DXd, but not yet using in this like healthy, fit, potentially more fit population than the metastatic that you think will be different as we use the drug early stage?
And one of the, you know, not uncommon complaints is fatigue. And I'm not sure with any therapy we have a magic solution for that. But again, I think it's just educating the patient about what to expect and hopefully reassuring them when they're beyond this, they'll get back to their baseline. But it wouldn't be shocking if they're going to experience more fatigue than, you know, they might have otherwise.
One question that I've already heard come up a little bit is about alopecia and scalp cooling. Any thoughts on that with an antibody drug conjugate?
I think it's a definite discussion that we have in the clinic with each of our patients, and a lot of patients nowadays are using cooling caps, you know, during the process of their treatment. So it's more and more universal that I see, you know, both in our practice and also in community practices as well. So I think it's an addressable question. We do know that this does cause a significant amount of alopecia. I think the other aspects also are GI toxicity and making sure that we, you know, upfront give enough antiemetics and antidiarrheals just to make sure that's covered. And then peripheral neuropathy, which is a more chronic related toxicity, as we know, likely from the antibody drug conjugate with the chemotherapy that's attached to it.
Yeah, great. The next section that we would move into a little bit is how we're using the T-DXd throughout the continuum, what early stage use might mean for metastatic breast cancer use. So obviously, Bill, you said this is a situation we hope to not find ourselves in because we're trying to prevent these metastatic recurrences, but inevitably we will end up here for some patients. So walk me through your decision making, you know, 2 years from now, if we're treating some early stage patients and they have recurrence, what would your thought process be about re-exposing to T-DXd?
Well, if they, so 2 years downstream from their last therapy, you know, if they had tolerated it well and we don't have some new magic bullet on the horizon, then I would think about revisiting it. And of course, we have other, you know, trastuzumab, chemo, trastuzumab, tucatinib options as well. But if they responded well to T-DXd and were benefiting from it, seemingly, I would at least think about it. Now, of course, we didn't want them to recur having received T-DXd, but I wouldn't automatically say that they're not going to respond in a metastatic disease setting.
Yeah, Dr. Khan, any thoughts on your side?
Totally agree with Bill. I totally agree with Dr. Gradishar. I mean, that 1 year interval is kind of what I would claim in my mind, right? In terms of reestablishing the drug back into the regimen. The other aspect of it is that 50% of the patients that are exposed to T-DXd, usually are HER2 negative, right? And we've seen that on repeat biopsy, so I would probably repeat a biopsy. If it's negative, then now we got to kind of rethink our plan in terms of reoffering HER2 therapy. The other aspect is that we have clinical trials that are now opening for these patients, and we want to make sure they're eligible for that as well.
Yeah, that's a great point. I feel like so often we're rebiopsying in the non-HER2 setting looking for HER2, but this is actually the converse, right? Are we so effective with our HER2 targeted therapies up front, will we actually see downregulation of that target, and the resistant disease could be something else? And,
Absolutely.
And one of the interesting questions that won't be answered by this discussion is we always talk about sequencing, but sequencing in the metastatic disease setting, this is sequencing in another sense too. So if they did end up being HER2 negative, having been HER2 positive, what's the expectation that another antibody drug conjugate, Dato-DXd or SASE or something else is going to work? And we simply don't know.
Right.
We're in a whole new frontier with this ADC data, given that this is, our first movement of a drug that we hinge so much in the metastatic setting now into the neoadjuvant adjuvant setting. We had that with TDM1 to some degree, but we were able to sort of push it aside because T-DXd was around, but now we'll be confronted with it in a much more realistic way, I think.
Absolutely.
So, speaking of metastatic treatment, so let's hope we don't find ourselves having to retreat patients that we've treated in the early stage setting, but thinking about if a patient presents to you with metastatic HER2 positive disease, this first line decision making centering around the data from DB09, where T-DXd plus pertuzumab challenging our standard taxane, trastuzumab, pertuzumab regimen, there's still some uncertainty about which way we go, right? I mean, I think the clinical trial was very certainly positive. The data that we saw presented here at ASCO 2026 showing depth of response, durability of response is incredibly encouraging. How are you making this decision? Is T-DXd plus P your automatic winner in this first line situation?
No, but again, I'll qualify that by saying, do I use it? Yes. Who do I use it in? I've used it in very young patients with bulky disease, sort of the one shot on goal kind of analogy where you need to get a response. So what am I going to do? I'm going to try and do whatever I think is, for that particular situation, the most effective. And based on these data from that trial, I think it is. But does every single patient with metastatic disease start out like that? Because you can still get a response if you use it second line. We know that from some of the many other DESTINY trials.
Yeah. Realistically, how many of your patients do you feel like don't make it to a second line therapy in the HER2 positive space?
Well, we hear the number.
Yeah.
And I know that matches my reality.
I agree. I feel like the numbers we've seen are much higher than I would expect. And maybe that's the U.S. experience.
Right.
But what has your experience been, Dr. Khan?
And we practice more in a breast cancer setting, so we see a lot of breast cancer patients. So it's a little challenging for us, and maybe we're more selective based upon what we do and what we see. But I see a lot more of these patients, and I treat them all. I would say a majority of my patients do get second-line treatment. So I think that's one aspect to it. But to Dr. Gradishar's point, I've kind of adopted it a little bit more in my practice, this regimen with DB09. And that's only because I see a lot of younger patients. That's the reason with this disease. The other thing is I want to protect them from intracranial metastases as well, right? So that's the other aspect of it as well. Now the question will come is, how long do we treat them for? Do we treat them till progression, which is where the trial was done? Or is there other aspects that we can do at some point where we can de-escalate therapy?
Yeah.
Some of that questions are still left to be unanswered.
Yeah, I think that's a very, very tough conversation. So since you brought it up, can I ask your opinion on it? What do you think about, because we also have the other thing we haven't talked about that's outside of T-DXd itself that we've gotten over the past year, of course, is, year-ish patina data, and then HER2 CLIMB-05 data with the dacatinib. So how do those fit into your decision-making?
Yeah, I think it's a challenge, and if we have, essentially near complete response that we see on our imaging scans, it's still palliative treatment, and so the quality of life of the patient and their overall progression through this disease process is also very important in terms of how we're treating the patient. So in some cases, I have gone to HP only to reduce the level of toxicity the patient is getting. So I don't completely de-escalate therapy to nothing, but I have done that. But I'm still waiting on data. Whether ctDNA will guide us in that direction, whether further imaging along with ctDNA will guide us in that direction is yet to be seen too.
Yeah, And I agree. We have patients who have done well with seemingly minimal toxicity, and if their scans are stable, we sort of keep going. If they're having a rough time with completely stable scans, then even in the absence of data, we may transition to an HP regimen. But I do think that, as you get out into the second year and third, it becomes a more relevant question for how long do you keep going with it. And there is no answer.
Right.
But in the metastatic disease setting where they get scan after scan and there's still some incremental improvement, I would keep pushing as long as they were tolerating it.
Yeah, I completely agree with that. I think this is probably the biggest area where my thinking has evolved over the last year, and significantly in the last week with the abstract we saw about the depth and durability of response, because as I highlighted earlier, I really didn't expect that we'd still be seeing patients getting incremental response approaching 2 years into this therapy. And it really makes you stop back and question, if you do an induction phase with T-DXd, it doesn't 6-8 cycles. Maybe we were thinking, borrowing from the Cleopatra experience, maybe not as biologically relevant here as that state where we really stop for toxicity, not for efficacy. So I think we are, again, more individualized, which is great. I think it's a great option for our patients to be able to flex with them as to how they're doing, what their response is. And, for those exceptional responders, give them some hope that hopefully this will last for a while. Yeah. In terms of how you manage the longer term toxicities, because obviously we do have these patients that may be on for years in the metastatic setting, how comfortable are you with dose modification or sometimes dose delays in the intervals for these patients to keep them on?
So I think the lessons we've learned with patients who've been on therapy of any kind for an extended period of time, we start to get a little more liberal in the interval between scans. You can go on vacation, we'll break you. We'll give you a break for a couple of months, we'll look and we'll resume it. So there's a lot of nuance in how we approach an individual patient. And, I think the longer their disease is stable, we're not assuring them they're cured, but I think we're more inclined to give breaks from therapy, dose reductions, delays, because the disease seems to be quiescent.
Yeah, absolutely. Any other thoughts there, Dr.?
No, I agree. I mean, it's a marathon. We know this, and this is how we discuss it with the patients, right? And I'm with Dr. Gradishar on this, which is, I have to kind of go with how the patient's plans are in this process as well. Do we lower the dose a little bit to help them kind of tolerate it better, or do we lengthen out the treatment a little bit to allow them to have a good quality of life as well? And how do we do our scans as we lengthen out the treatment as well? And so I think those are still challenges. I think the real world data still have to kind of come through and help guide us as well.
Yeah, it's kind of amazing how early on we are with the real world data in the space, because the space has evolved so quickly that it feels like we've been doing this approach forever, but it's really only been a couple of years, right? So for especially some of these long-term responders, we don't really know what people actually did with the management over time. So in our closing moments together, I'd love to hear what you think key pearls, key practice management steps for our colleagues throughout the community are when you're thinking, let's start with the early stage setting, when you're thinking of incorporating DB05 and DB11 data?
Well, I think that the most important thing is to get some familiarity with the data so that you understand the impact it potentially has, both as a neoadjuvant therapy as well as a treatment for residual disease. And I think once you see that, you can actually visualize it, it becomes more profound that you're impacting on patients in a significant way. With respect to just implementing and either one of those, I don't think it's a particular challenge. I mean, I think these therapies, whether you use it, as a monotherapy, post-residual disease, post-neoadjuvant residual disease, or you use it as a component of a sequence preoperatively, these are not unfamiliar concepts to oncologists. So I think they just have to try it and recognize that, for most patients, they're going to do okay, but to really understand the data. that if they understand the data, they'll understand the impact they potentially have.
Yeah, it's very motivating when you really think about how many patients we may be hopefully curing with this short duration, either upfront or maximizing the impact on those patients that are at highest risk in the post-neoadjuvant residual disease setting. Dr. Khan, final words for us.
I think this is a wonderful time to be in medical oncology, particularly in breast oncology, where we have one of the most active drugs that we've seen in the last several years now be incorporated in the neoadjuvant and adjuvant space. Hopefully, like we had spoken here, is that we'll see less and less patients in the metastatic setting and a lot more patients potentially cured at upfront surgery following initial DB11. And hopefully we can keep them without metastatic disease via DB05. So hopefully those are the thoughts that I have.
That's great. I think that's a perfect message to land on, curing more patients, right? That's our whole goal. So we want to be obsolete at the end of the day with all of this. So with that, I'd like to thank our audience for your attention today, for our panelists, Dr. Gradishar and Dr. Khan, for your attention, and we look forward to seeing you another time.